Welcome everyone to our first really official kickoff of the CTC seminar series for cancer prevention and control. We are so glad to have you all here, and we have a year ahead that is really exciting with a diverse and varied group of researchers that will be presenting. And we are so thrilled to kick off with Dr. Candrian, who's an associate professor in the Division of General Internal Medicine. And it just happens, whether it's like kismet or serendipity or just dumb luck, that it is, I've just learned, is National Coming Out Day today. And Dr. Candrian will be talking to us about LGBTQ patients and palliative care in this space. And I also learned that her work is featured in USA Today of older lesbian women. And so please also take a moment and check that out. And that's just like the tip of the iceberg of the media and interest in the national press that Dr. Candrian's work has received. She is a Cambria Leaders Scholar. She has a KO1 from NIA, has been funded exceedingly well through the Commonwealth Foundation and other really important, that I'm going to have to look just because it's such a long list: the Colorado Trust, the Colorado Health Foundation, Next 50 Initiative, the Lesbian Health Fund. We are thrilled to have you present. Thank you so much for being here.
Thank you, Dr. Fisher. Thanks for having me, and thanks, Ryan, for all your help too. And thank you all for coming. I like small groups. Can everyone hear me okay? So I'm here to talk about older LGBT adults in particular, the disparities they face, and the way our communication can impact health outcomes. And as we all know here, dealing with serious illness is hard. It's hard for everybody, but it's even harder for older LGBT adults. Why? Basically, they're entering this last phase of life with three major disadvantages: financial, social support, and the lifetime of stigma and discrimination. First, financial. 1 out of 3 older LGBT adults live at or below the poverty line, a third. A lot of this is directly related to the fact that a lot of them have a very thin network of support. For example, older LGBT adults are 2 to 3 times less likely to be married, which means they're more likely to be living on a single income, and often they have less access to spousal benefits. And another big factor related to financial discrimination and financial disparities is really this lifetime of job discrimination. If they were open about who they were, they could have been fired, and many were. Second, social support. LGBT older adults are 3 to 4 times less likely to have kids. They're more likely to be estranged from their family, which means they're less likely to have help with care, advocacy, and support as they age. Underlying all this is a lifetime of stigma and discrimination that has concrete health effects. Research shows that stigma and discrimination disproportionately affect the LGBTQ community, putting them at risk for a number of issues, like higher rates of anxiety and depression, substance abuse, cardiovascular disease, cancer burden, especially lung and breast, and suicide. For much of my career, I really wanted to understand what specifically was contributing to these disparities and what we could do about it. And the thing is when you're dealing with health disparities, we're dealing with a lot of data, a lot of numbers, and a lot of statistics. And as a researcher, I do the same, data and statistics. But the numbers can't always tell us the stories. They can't tell me how and why some of these things are the way they are. So I wanted to dig deeper. I really wanted to bring these statistics alive and really be able to see the people behind the numbers and the impact they were having on real people's lives. So as a result, I've interviewed probably over 100 LGBT older adults. One of them is Pam. She's in her 70s, and a lot of what she told me about growing up in the 50s was that being gay or lesbian or trans was unthinkable. In this first clip, she's talking about the 1961 film, The Children's Hour, featuring Audrey Hepburn and Shirley MacLaine. Here she is.
It's Lillian Hellman, and in short, there's two young women who are running a girls' school, and it turns out that one is a lesbian and one isn't, and the one who is killed herself. So it's not a happy story, but for me, it was fabulous to find out that that category of person existed. So I would say from 8th grade on, I kind of knew it, but the vocabulary, gay and owning dyke and all of that didn't happen until basically after Stonewall. Stonewall happened when I was a senior in college, and so the vocabulary to describe myself came out in the 70s.
Keep in mind, for many of these older LGBT patients who grew up in the 40s and the 50s and the 60s, it was dangerous and even illegal to be LGBT in many states. If you were in public with a same-sex partner, even just holding hands, you could have been thrown in jail, could have lost your job, could have lost your home. Up until 1973, the American Psychiatric Association listed homosexuality as a mental disorder. Like, just imagine growing up with this kind of stigma, with literally thinking that something's that wrong with you, that you were sick because you were LGBT, and how incredibly vulnerable you would be, and how ingrained this stigma would become, and how it would influence how you move through the world, what you share and what you don't share. To give you a sense of how pervasive these norms were, here's Pam again.
It was the summer I was 21, about to go into my senior year of college. And up until then, it was incredibly dangerous to even think you were gay, but
So is it any surprise that so many of these older patients who are LGBT, who grew up in this culture, have honed what I call this habit of silence about a fundamental part of who they are? And they've honed it for decades. Silence was and still is a critical defense strategy, and this habit of silence still exists. It exists in general, in all aspects of their lives, but importantly for us, it exists in medicine and healthcare. 48%, almost half of LGBT adults, say their own doctors and those who care for them don't know that they're LGBT because they're afraid if they tell them, their care will get worse. And they're not crazy for worrying. In 2021, 56% of LGBT adults report experiencing some form of discrimination from a healthcare professional. For those who are trans or gender nonconforming, it jumps to 70%. This kind of discrimination is happening all over the healthcare ecosystem, including hospice. In a 2020 survey of over 850 hospice professionals, 45% of the staff directly reported experiencing or observing discriminatory behavior towards LGBT patients. Everything from rolling eyes when patients were holding hands, to excluding partners from major decisions, disregarding patient wishes, outright abuse, and denial of care. In another survey, 2023, just this year, a survey of 290 LGBT patients and partners reported that things are still bad. 35% of LGBT patients and partners said that their providers were insensitive because of their sexual orientation or gender identity. 30% said that their provider and those who care for them were unaware of their unique needs as an LGBT person. 23% felt that they were judged because of who they were. 20% experienced rudeness from those who were taking care of them. 20% said that their provider and those who care for them use incorrect pronouns, misgendering them. 19% said that their decisions were outright disregarded. And for patients, and for Black and Hispanic patients, they were 2 to 4 times more likely to experience discrimination. Because coming out can literally be a risk to their health, and especially their health care, a shocking number of these older adults don't come out until their 70s or their 80s, if ever. Like, just imagine hiding something so essential to who you are for so long. And the stress of hiding takes a serious toll. According to Harvard Medical Magazine in 2020, the stress of hiding something so critical to who you are can take up to 12 years of your life. About 3 years ago, I interviewed a woman named Esther. She'd recently lost her wife, Kathy, to cancer. And the thing was, when the hospital staff realized they were a couple, Kathy's care got worse. So they felt like they had to hide the relationship. When I asked Esther what the hardest part of this whole thing was, she said, "My wife was dying and I couldn't even say we were married." Since they were hiding their relationship, Esther couldn't be in the room. She couldn't advocate for her wife on any level. She couldn't be there when the care team was talking about next steps, treatment, and future planning. She couldn't even hold her wife's hand. When Kathy died, nothing. No one said a word to Esther. They had been together 33 years. What Esther's and Kathy's story reveals is really how communication impacted the outcomes of two people. Kathy's care got worse. She didn't have the person she needed to advocate on her behalf because Esther was shut out as non-family. She was just a good friend or the emergency contact. And Esther got no grief support. She was just a friend in most of the providers' eyes. Not a grieving spouse who just lost the love of her life of 33 years. Like, just imagine how this would be when you were going through something like this. Sadly, Esther and Kathy's story is not unique. This is a choice LGBT patients face all the time. Do I come out and risk being treated poorly, risk not having my partner in the room, or do I stay silent and hide a fundamental part of who I am and who I love? It's a heck of a choice. On the one hand, we have documented discrimination and disparities in outcomes. On the other hand, we have people who are almost professional level at hiding and rightfully afraid to disclose who they are. And it's all happening in the healthcare system that really limits the way people share critical information about who they are. Just think of some of our forms. Male, female, although this is changing and fortunately improving. Or single, married, widowed, divorced. What if you're Esther, together 33 years and not married? People say a lot that words matter, but it's more than that. The way we talk and the way we listen to each other has an effect on people, both positive and negative. And unfortunately, this will continue unless we make it really clear that it's safe to share this information. This matters in all areas of healthcare, but it's really critical in serious illness and around end-of-life care. So what can we do? Legislation is one thing, giving protections to people that are long overdue. But we can't legislate the way people think and feel. What we can do is change the way we communicate, the way we talk, and the way we listen. And one big way is what I call breaking these scripts. A lot of the way we interact in medicine is very scripted. The forms, the intake calls, the admission conversations, sometimes even literally dictated by drop-down menus in the EMR. But we have to break these scripts, and we have to open them up in a way that gives people space to answer in a way that actually fits them and their lives, and take the burden off the patient so they don't have to be the ones to come out over and over to a battery of new people when they are sick and scared and exhausted. So just go back for a second and think about some of the ways we get to know no patients, the forms, the admission conversations, the intake consults. They're critical tools in medicine because they tell us who a person is, what they want, and what they don't want. But the thing is, these tools are very scripted, and they're loaded with assumptions that aren't always spoken, but they're definitely heard, especially when your life doesn't typically fit the script that they're designed for. When the question is, are you married? How do you answer if you're not legally married? But think about what we really need to know here. We don't care if someone is married. What we really care about is the who. Who do they want in the room when we're talking about diagnosis, treatment, and planning? Who will be caring for them at home? Who would they like to make decisions if they're not able to? So what if instead of asking, are you married, we ask, who's the biggest support in your life? Do you live with anyone? Just think how different the outcome could have been for Esther and Kathy. Another script we use and hear a lot is around the family meeting. But like marriage, family has a lot of boundaries. They can box people in or box people out. Countless LGBT people have been estranged or really cut off by their family. So when this word is spoken, a lot of times we might not get the information that we really need, which is the who. Who do they want? Who do they need to have with them? So what if instead of asking questions specifically about a family, we ask who needs to be in the room when we talk about your care? Who's going to need support so they can support you? Who are your people? I want to switch for a moment from the forms to talking about things like goals of care. When hopefully people are telling us what and who matters. This is Janelle, a woman who I interviewed, and she transitioned in her 60s. In one of our conversations, she was telling me some of her biggest fears as she gets older and if she were to get sick. You'll have to listen really carefully because in the audio, you can hear the fear in her voice as she's talking. Here she is.
As far as palliative care, yeah, I do have concerns. I'm worried that certain things will be outside my control at that point. And I
What do you
will,
mean, like?
like, I still have to shave, for example. I don't want to hear on that face.
She says, I still have to shave. I don't want to have hair on my face when I die. Here's Janelle again.
I will be perfectly honest, that one of the things I think about a lot before I transitioned was I don't want to die this way. You know, I want to be buried as a man. I don't want to be buried as a man. I don't want a man's.
She says at the end, I don't want to be buried as a man. I don't want to have a man's name. Think about one of the last conversations you were part of, the questions you asked or heard or questions heard. Where in those questions would there have been space for Janelle to share information like this? These stories are not unique, but one of the things that gets lost often when we talk about the LGBT community is our common humanity. In medicine and healthcare, we work with people. Individual people, ordinary people trying to live their lives and get the best care as possible. People who are our neighbors, our friends, and our family members. The problem is when we start talking about groups of people, it's very easy to get into generalizations. And where there are generalizations, there can be a lot of fear. Fear of the unknown, the unfamiliar, the uncomfortable. And this shows up with the LGBT community, not just in our personal communication, but also in organizational level communication. And given this historical context that so many LGBT people have grown up in, including the current culture that we are in, it's really critical to not only be welcoming as individuals, but also as teams and institutions and organizations. So here are some specifics, things that we can do, that you all can do in addition to language. We talked about forms, signs and symbols, pronouns, email and letter signatures, websites, policies, and trainings. And just to give you some examples of what this looks like, this is my badge. Lanyards and pins and stickers are a great way of showing signs and symbols, writing them on your shirt. Signs, probably all look familiar. The point is these signs and symbols matter significantly to the LGBT community. We look for them wherever we go. They can be small and subtle, but they do tremendous things to cue that this is safe. A lot of these signs are around safety, because in many places it still is dangerous to be open about who you are. So any sign and symbol to let people know that you're okay, that this place is okay, goes a really long way. Pronouns are another great way. We have the pins here at CU. Or when I say them, it can sound like this. Hi, I'm Carey. I use she, her pronouns. You can also put them in your email signature if this is comfortable. Again, these are things we all look for that can really send a signal that it's safe. Even in office spaces, any, again, sort of sign and symbol, which is really the point in all this. How can you send a signal that it's safe, that this place is okay to be who you are? How many of you are familiar with Dr. Jean Guttner? Something? Okay. She's one of my favorite people. And I was fortunate to make a documentary last year that is a lot about this, helping to understand the disparities older LGBT people face, really the LGBT community, impact it has, and really the impact it has for healthcare. And here's what she had to say.
My name is Jean Kuttner, and I am the Chief Medical Officer at UC Health, University of Colorado Hospital, and I'm a professor of medicine at the University of Colorado School of Medicine on the Anschutz Medical Campus. I've been doing this role for about 8.5 years. It is really bringing the voice of the providers, the physicians. We have trainees working with our advanced practice providers, bringing that voice to the executive suite. When I care for patients, I think it's really important to get to know who they are as people. That is probably one of the most important things I do, is who are they as a person, what's important to them, who is their support structure, who and what do they define as family? How do they want to be referred to? Who is that person? And then I can then work with that person around whatever those health challenges are that come their way.
I am going to have to rely on professional support and services. I'm going to have to rely on someone to give me my testosterone once a week. I'm going to have to make sure that if something were to happen to me, that I have paperwork that makes sure that my spouse is going to be the one to be there, because we weren't legally married at that point. And if something were to happen, they would have called my parents, who were not part of my life.
When you're dealing with serious illness, and especially if you belong to the LGBTQI+ community, there's a lot of fear, and the stigma that has been experienced over a period of time can become much more magnified. And because you are at your most vulnerable point in your life.
I can just see the toll on people of not being able to share who they are, I think, and who they love. I think there's multiple consequences. I mean, somebody who has a serious illness is already often struggling and often has distress, and it's not just the physical distress, it's sort of existential, psychosocial distress. And if you're not able to be your authentic self and to share who you are, and it just adds to that distress in incredibly burdensome ways from a very practical standpoint too, in terms of, who is allowed to stay with people, who do we turn to for decision making. If we don't know who is important to somebody, and, as a spouse or as a partner or as a loved one, then we may make some terribly wrong assumptions and be not including the right people.
So this is what's happening on the individual level, and really the effects that communication can have on being able to have the right people or not have the right people. And now I want to zoom out before I close and really show the impact that communication specifically in this habit of silence is happening on the macro level. Basically, what's happened is we do not have complete and accurate data about the LGBTQ community, otherwise known as sexual orientation and gender identity. In large part because we don't routinely ask these questions, which means that LGBT people are absent from a lot of or invisible from a lot of the literature influencing practice. Funders often don't require these data to be collected. Registries trying to improve quality often don't include sexual orientation and gender identity. And without good, and by good I mean accurate, complete data, it's really hard to even know how many LGBT people we're talking about, what their outcomes are, and how to meaningfully address these disparities that they face. It also makes it really hard to develop targeted interventions with such incomplete data. These structural practices around data continue to keep this community hidden. But by asking these questions, we can actually change this by routinely and safely asking these questions in a way that doesn't perpetuate discrimination, but they become habitual, just like race and ethnicity, that these questions are just part of the demographics. And I realize that some of these tips and even some of these questions might feel awkward or uncomfortable or intrusive. Maybe you're not sure what to ask or how to ask or when. But the point is, and I think the more you do it, the more comfortable it will feel. And hopefully by having these examples at many different levels, some of them might feel comfortable to implement, and some of them might be a way to just send subtle and small cues that can help the LGBTQ community feel safe to be open about who they are. Because the bottom line, all these really signal that it's safe to be who they are and helps you know that you're caring for the whole person with the whole story and the whole information. Because remember that LGBT adults, and not even just adults, have literally honed this habit of silence, have been trained to stay silent about who they are for decades. And it affects what they share, what they don't share, with whom, and when. So we have to be proactive here at every level and every interaction. And think about what information you really need to know. Does the way you frame your question give space for lots of different types of answers? What if you were trans and had to answer it? Or if your family had rejected you? Or if you're with a same-sex partner, but not actually married, does your question shut them out? Or does it invite them in? Does it say, hey, I'm okay with who you are. You can be safe here. All the LGBT older adults I met in my research, they're really not asking for a lot. They just want to be able to talk openly and be heard without prejudice. And all we have to do are break these scripts a little, show them more space, give them space, and listen. Thank you for listening today. Yeah.
I have a question. Thank you so much. The pictures are beautiful, and it's really feels really important to hear not only their words but their voices too of your participants and the people you've engaged with. In thinking about the tools and how we, as those of us who are clinicians in the room, do ask those questions, and thinking about also just as a palliative care person, and we talked a lot this morning about how words matter, and as we ask this question, I worry too that the country has become in some ways moved in wonderful directions, and in some ways become more polarized, and wondering how do we respond when someone responds to that question with anger, and just thinking through.
Yeah, it's a great question. Specifically the questions like these around sexual orientation. It's a great question, and it's a really challenging time to be doing this work to tell people the importance of these questions. As my answer, and I think a lot of what the community would say, is also that the more routine and habitual these questions become, it's just going to be, like we ask these questions for everybody to help us make sure we have the complete information. I'm not trying to make that sound like a cop-out, but I really do think the more that these things are just like age, race, ethnicity, sexual orientation, the more people get used to hearing them, the more people realize that this is just standard things we ask. And yeah, I think that if they're uncomfortable, it's okay. They can be uncomfortable for a couple minutes of their day if it means, finally an opening for so many of these people. So my answer is just that the more these things can just become routine and just sort of common practice, the more people will, I think, have enough room to really push back on. But it's a great question and a really challenging, time to get. Yes.
Thank you so much. This is a great presentation. And just jumping off of Stacey's question, I'm about to embark on a couples-based clinical trial for behavioral intervention. And as you know, there is a significant paucity of LGBTQ couples in research, whether that's, and I imagine part of it is because our recruitment strategies might not be hitting the mark. And I'm wondering, from your experience, do you have any specific words that you use on flyers or terms or sayings or ways that we can be thinking about how to improve recruitment and then continuing to keep them in the study?
That's a great question. Have you started?
No.
No.
Have you look at my stuff later?
I'd be happy to. I do think partner or partner, partner is a great or couple getting it out. Not that you'd be able to give a.
Well, the study is called Partners Coping Together, a PACT study. But I'm wondering, could we say something like couples from all backgrounds or couples of all orientations are welcome? Is there something?
I think that, I was thinking because something else like we're looking to interview partners of all different sexual orientations would be a great way. I know like therapists do that on there. And it's immediate sign that you're able to participate. And you might even have pictures of, a hetero couple, two lesbians or two gay men, something just to see themselves. That's great. And then I think another thing I'm happy to talk more is a lot of when my recruitment methods don't look a lot like normal ones, just because sometimes you have to go to choir practices or community events, and a lot of it is word of mouth, just knowing that they have a lot of mistrust with research and just all of this. So I think just making sure that you're going to places to a lot of the community organizations, and recruiting there, because they're less likely to be like in an elevator to see a recruiter. I'm happy to help in any way. Cool.
Thank you.
Thanks for doing that work. Yeah.
I had a follow-up question to what you were kind of suggesting, kind of lumping it in, lumping these questions in clinical care with like demographic questions. And I think I was curious, as a provider, I don't ask race ethnicity questions typically. I think that comes like with their initial intake.
Yeah.
Do you feel like these questions should be in that space as well as one face-to-face with providers, or is like one preferred to the other, or is it?
It's a great question. I'm doing a study just that's asking about this in hospice, but there's been the quality study looked at this in the emergency department and actually found that the more often it's asked, the better. So intake forms, they can fill it out. But then they also showed just again this, because the habit of silence, the more opportunities they have to disclose this information, the better. I think when what they've shown is that if it's at the intake form, that this comes out so that there's still openings for them to say, who's the most important person in your life, who do you need in the room. But I do think the more opportunities they have to disclose this information, the more likely they will. Because the form might feel, a lot of times they feel like no one's going to read this, or that's actually more vulnerable to have this form be exposed. So I think it's actually more important for the face-to-face for it to come out. That answer? There's been another one. Lexi, do you know what the other one was? It was after the quality, maybe it was in primary care but they looked more at like, are people willing to disclose this? And yes, both of the studies found that they were. But in terms of where, I don't know of any other.
Yeah, I'm not sure.
No, those two.
There's a question. Linda's got a question. Linda, go, please.
There you go. Hi, great talk. Thank you very much. I was really struck by, your examples with the forms. And this kind of, also is kind of a follow-up to Lauren's question about, what should be included in research studies and how do you present things? Are there any resources available? One is my first question, other than you, of course, but I mean, are there just kind of general resources available that can really help people if they're putting together a form? And two, is there any move at CU Health to change their forms so that at least within the CU Health system, this information is more readily available? So I guess there's two questions there.
Great, thank you, Linda. Yes, the resources, and maybe I can send them to Ryan and he can send them out. But so Sage National is the largest advocacy organization for LGBT specific older adults, and they have a lot of just like 101 how to ask, suggestions, recommendations. Williams Institute at UCLA is also another good one. But I will send these out. But just give some samples about how to ask and when to ask. Related to CU, I do know they've changed their forms. I know Dr. Rita Lee has been a huge advocate around all this. I think one of the challenge, and Stacey, I'd love for you to chime into, is that, which we not only see at CU, but just having them on the forms is a critical first step, but without proper training and education, it falls short very fastly. So why are these things being asked? How can they be asked in a way? There was one group that actually showed, I think it was the palliative care quality, one of PCQC, found that majority of people were marking patient refuses to answer, which was actually a result of the providers not asking. So there's getting on the forms is great, which we have, but without the education and training, it's really critical that follows. And I think another thing is that the pronouns are great. But it's not it doesn't capture the SOGI. That's a great first step, but I think people feel like they're done with that. And a lot, like you probably noticed, I haven't used the word Q a lot. It still is in my pronouns. LGBT queer is still a very derogatory word for a lot of these older adults, and it's a word that a lot of the younger generation identifies with. And similar to pronouns, pronouns still feel very weird for older adults, so that's not gonna be enough. So yes, CU is doing good, and I think they're trying to do more training, but it's a huge problem across the board now too, is that they're adding them and just expecting people to get this information. But I will share the resources too. Thanks, Linda.
Thank you.
Yeah.
Kind of like piggybacking on that. So I'm a data analyst on like the population level, and oftentimes when we look at like disparities within Colorado, it's very easy for us to like pull data on racial disparities.
Yeah.
But we often get questions about, are you able to show any disparities by like gender identity? But the biggest issue is that there are some areas in the state that, you know, they're trying to collect that information, and other areas where it's like not even a discussion. So I guess like what can be done to make that more like widespread? Because there are obviously smaller studies or like surveys that have been done in very specific areas that show that there are those giant gaps in healthcare, but like how are we supposed to capture like the whole picture? Yeah, I don't.
It's a fabulous question, and it's like and that's why it's like it's such a wicked problem, and a lot of it is really related to communication, and now with what's happening, that to know that people, I mean, if you disclose who you are, and you can be denied care, so it's very scary to be. I mean, it's always been scary, and it's even scarier now.
Mm-hmm.
And so like these signs and symbols might really feel like superficial, but I really, they're critical. And especially now is like when they used to wear the triangle to know that people were safe. It feels like it's almost back in that time that you really have to have a sign or symbol. So I don't know. I know there's push like from CMS, although their last report was pretty weak, that these will become required in 2024. But I think unless it's coming from the top and also the bottom, it's not gonna happen because of what's happening.
Yeah. And then like a follow-up question. Have you, I guess, asked, so like, are there different responses or just like general feelings when the medical provider is also a member of the LGBT community? Yeah, I guess, have you looked into that?
There's been a group in Canada that's looked at it, and yes, it matters.
Okay.
And then I think though that on the same time they struggle with if they should be open, how they should be open, but yes, it matters. There's a difference. Yeah.
Similar kind of question, based on the evidence that you do have, do you see outcomes like patients feeling less stigmatized or less lonely or more supported when these types of kind of simple questionnaires have been changed and things like that?
Yeah, SAGE actually did a study and showed that 80% of LGBT adults, when they knew that their provider was affirming or the organization was affirming, they felt more satisfied with their care, which is a lot.
Okay. I was thinking, you know, because there's a lot of compelling data about loneliness and poor health outcomes, early mortality, people who are more lonely, and I can imagine that's even more, you know, salient in this population.
Then you get into that, is
that kind of the case? And
it is the case, and especially they did actually a great report on long-term care and LGBTQ people just last year in the Colorado Trust. Claire Cleveland, who was from CPR, and showed exactly that, is that there's actually 75% will go back into the closet, which when they enter things like long-term care, which just exacerbates the loneliness. So you can't be open, you can't talk, and then it's just a vicious. I mean,
I imagine
is like quadrupled.
Yeah, it'd be like loneliness times the stigma times the lack of social support. And I'm just picturing the Kaplan-Meier survival curves of just how that probably plays out. And then thinking, you know, are these simple ways of making people feel more safe or included? Could that help mitigate some of that?
Yeah, it really, and then if you add on race, ethnicity, or disability, it's like layers and layers. But they, in Day Springville and Denver, they started an LGBT group, and originally they had two, and now two people, and now they have 25. And they it's monthly, but they wait for that group to happen. So it does. I mean, just sort of, and they say I look at that calendar because they just need to be around other gay people. I just need to be able to be who I am for an hour per month, and they need to have more. But it matters. the science and the symbols and the programming. Go ahead, Gina.
I just had a follow-up question to what you said about how your recruitment methods look a little different. When
Sorry to write up.
yeah, when I've just moved from Massachusetts, I did a lot of work with community health centers, and we had some times where we were working with our health center partners and how they sort of built trust and built that partnership with their community. And when we present that, we'll often hear people ask, well, how do you write that into a grant? Because like all that time that you put in to listen and be present and show that you care and are there for the partnership and not just sort of swooping in and out for a research study. I'd love to hear sort of how you make it work. The grant? Okay, maybe like, yeah.
Well, actually, very sore subjects. I've been like bragging about how lovely the IRB is, and this last one has been, because it was like, we'll use word of mouth and existing relationships with community, and it was like such a ridiculous response back, and I just decided to actually just write a paragraph like, this is a community that is like basically a lot like this, like, and I'm not sure how they're going to respond to it, but it's hard because I know Stacey, like the community based was, Gina too. I mean, this is still, I think it's getting traction, but it's still very new. And I think people totally underestimate just how much time is going in. I don't know that I have a lot of great ideas. It's just like what's been sort of the absolute bare minimum that I need to include to feel like it's still authentic. And then being able to frame it in a way that people can also get it, that it still sounds kind of rigorous. I'm happy to share things. I do think though, like having relationships with the IRB, having relationships with the program officer do help, and people are more open to that. But it's I think going to be a huge disparity and challenge to do a lot of this work, because I think any community that's not sort of the general public requires a lot of creativity and innovation.
Trust takes
Happy to
time.
chat more. Trust
takes time.
And it doesn't always fit very nicely into a grant, which is why most of my funding comes from foundations, actually. I see.
I have a question with something that I sometimes wrestle with clinically. So I might see a person, particularly an older couple, or an older adult who's, like healthcare representative is listed as friend or roommate. Yeah. And I struggle because, you've pointed out that there is genuine risk to me asking about the relationship and then documenting it in the medical record. And of course, it's more honest, which is wonderful. But one, they might, because I love the term habit of silence, which I haven't heard before, and I think that's perfect. And sometimes they might know that I'm LGBT as well. And so I feel like there's this trust, but like, they might know that about me and they might be okay telling me, but then if I put that in the medical record, it might lead to genuine mistreatment of this couple. And so I guess I feel like I'm just struggling with sort of navigating that aspect of it, is they might want to continue to be known as the roommate so that they don't experience discrimination in healthcare. I wonder what you think about that.
It's a great question. Have you, it's a great question. And the biggest challenge, I think, with working, I think it helped, in like, even at the document, but in the conversations, like with care teams, like, I just saw Carey and her wife, Marty, or like just talking more about these things, about couples and different orientations and identities, in a way that just we start hearing them without making it sound sort of weird or different.
Absolutely.
Because now when I hear Carey's roommate or Carey's, I'm like, yeah, right.
I know that's how I feel too, but I'm like, what do I say? Like, do you, I know that's not really just your roommate, but they might want to maintain that. They might want to be closeted. They might not want me to know. Yeah, and that's what I think. I think that's a huge part of the solution.
Asking them, are you comfortable with me documenting this? I think is totally reasonable.
Yeah.
And then I do think the more you just hear.
Right.
I think it's a great question. Extrapolate from, I'm in pediatrics, so I always, when I'm asking this question, the family's out of the room and everything, I always ask like what they would like, how open they are with their parents about it. So and so I end up asking them the question of like, I can put this, if I need to document something, in a note that they can't see, or do you care? Like, it's kind of the same idea.
Yeah, absolutely. And you can keep notes out of the patient portal, and just different ways to keep things private.
So a lot of parallels, oh, sorry.
No.
There's a lot of parallels with talking about sexual health, it sounds like in general, of just asking people about their sexual function and sexual side effects of treatment. And I wonder if looking at that literature around clinical communication, like the implicit model or other ones can give some guidance on how to ask these sort of orientation or gender identity questions in the room too, because I think it's like a slippery slope or maybe this kind of a taboo subject in general clinically that needs to start with the clinician.
And I think that's a big part of the taboo is that it's so often linked to the sexual act, like that this is like off limits information because it's still so deeply tied to sexual history. And I think the more that those can be broken to like who you are, what's important that I know about you, the better too. But I think that's a huge taboo that it often gets to who you're having sex with instead of who's the love of your life, who needs to be in the room. What's important about you that I need to know. Great questions, thank you.
Any other discussion? Well, join me in thanking